Thank you, Dr. Christopher. That was really inspiring, and also I think gave us all a lot to think about. For the record, the American Public Health Association completely supports this concept in health and all policies. Our annual meeting this year has that as its theme, and we recognize that we are going to be working on things as a public health community that nobody thought of was public health just a few years ago, and that's the only way that we're going to make a difference in reaching our goal. It is now my distinct pleasure, again, with technology, to introduce you to the president of the American Public Health Association. Dr. Shiriki Kumanyika is the emeritus professor of epidemiology at the University of Pennsylvania School of Medicine. During her 15-year tenure at the Penn Medical faculty, she served as the Associate Dean for Health Promotion and Disease Prevention, and was a founding director of Penn's multi-school Masters of Public Health program. At the same time, she held a secondary appointment in the Department of Pediatrics. Dr. Kumanyika founded and chairs the African American Collaborative Obesity Research Network, a national network that seeks to improve the quantity, quality, and effective translation of research on weight issues in African American communities. She's also the vice chair of the Department of Health and Human Services Secretary's Advisory Committee on Health Promotion and Disease Prevention Objectives for 2020, is co-chair of the IOM's Committee on Childhood Obesity Prevention and of the International Obesity Task Force, and is a member of the World Health Organization's National Guidance Expert Advisory Group. She has extensive experience in advisory roles related to public health and nutrition policy in the US and abroad, and is currently a nutrition epidemiology advisor to WHO and the World Cancer Research Fund, and the co-chair and the Policy and Prevention Group of the World Obesity Federation. And it really is my pleasure to introduce our current president. Thank you.
The one with the face speaking. That makes sense. I come from a day when they wrote things out for you. They didn't give you little pictures to react to. Thank you for coming, and thank those of you who are participating through the internet for joining in. I should tell you that by signing on to this program, you've become a part of the social movement if you were not already. So this is, as I say, leave now if you don't want to be a part of the movement, because I think that we need all hands on deck, and we have a fantastic opportunity to really make a difference. I love this analogy of public health 2.0, upgrade. We need to really get into the next phase and do some transformative work to achieve our goal. So we're going to kick off the discussion about solutions with a very distinguished panel. You have the bios of the three panelists in your information that was distributed, so I would just highlight their affiliations and what they bring to this panel in terms of topic. And then they will each take 45 minutes to talk about their area of interest and the types of solutions that they're involved in. Then we'll start the panel discussion with maybe one question from each panelist, but please begin to write down your questions as we proceed so that we can have a dialogue at the end. So first we'll hear from Dr. Tom Farley. He is the CEO of an organization called the Public Good Projects, and you'll hear more about what that organization is from him. In brief, it's a media effort to improve the health of the nation. And many of you in public health, and not in public health actually, will know of Dr. Farley from his time between 2009 and 2014 when he was the health commissioner for New York City. And at that time, he really was involved in mass media campaigns. There were some very powerful, sometimes controversial media campaigns. One was Pouring on the Pounds about sugary drinks, and the other was 2 Drinks Ago, which was a campaign to reduce binge alcohol drinking. And they also had a lot of hard-hitting ads on the consequences of smoking. Following Dr. Farley, I'll introduce all the panelists at once. We'll hear from Dr. Linda Blount, who is the president and CEO of the Black Women's Health Imperative. I do have to say that at one time when it was called the National Black Women's Health Project, I was actually on that board of directors, and it is an organization for really improving the health of the Black community and working for reproductive and social justice for Black women across the lifespan. Dr. Blount, Ms. Blount, before she was in that position, was Vice President of Programmatic Impact for the United Way of Greater Atlanta, and she led a team focused on achieving transformation in health, income, education, and housing stability through place and population-based work. And she was also, prior to that, the first ever national president of health disparities at the American Cancer Society, where she was similarly responsible for strategic visioning and leadership to that society. And you can read the rest of these bios in your information. The third is Dr. Soma Stout, who is the Executive External Lead for Health Improvement for the Institute for Healthcare Improvement. I will say that I first encountered Dr. Stout at a program that the Robert Wood Johnson Foundation had when they were honoring 10 people who had been selected from about 900 nominees as young health leaders. And this young woman got up when she was being recognized, and I thought after I heard her talking, she's going to transform the whole healthcare system single-handedly. She had her ideas, she had her strategy, and one of the criteria for this award is that you had to be under 40. So what Dr. Christopher said about youth are going to lead the movement, I think we represented well on this panel by Dr. Stout. She serves as the Executive External Lead, as I said, for health improvement. She's currently leading in that role a global initiative to improve the health and well-being of scale 100 million healthier lives. That's a campaign that you might have heard about. So she'll be talking to us about transforming the whole healthcare system and the implications of the Affordable Care Act and so forth. So without further ado, I'll turn the program over to Dr. Farley, and we'll hear about the public good projects.
Thanks very much. As Dr. Kumanyika mentioned, I am the CEO of a new organization called the Public Good Projects. And we are beginning a new initiative that we are calling A Healthy America, which aims to use the power of the mass media and the techniques of marketing to try to address our nation's biggest health problems. In public health, we haven't used the power of the mass media much over the years, but to the extent that we've used it, for example, in addressing smoking with ads you see on television that encourage people to quit, to the extent we've used it like that, it's been not only effective, but also cost effective. And so we think this is very much an underused tool. It's a tool that could be used to address behavioral determinants of health. It's a tool that can be used to address policy determinants of health. It's a tool which can be addressed, focused on individuals. It's also a tool that can lay the groundwork and push policy change. So our initiative is about trying to harness those tools and with all the things that modern media can do to really tackle our biggest health problems in a big way. And we expect this will be we'll be in this work for decades. It's not something that's going to happen very quickly. But we're excited about that opportunity, and we're trying to get as many other people as excited about it as we are. That's all I'm going to say for now. I'll add more later.
Okay, great.
Okay. So good afternoon. I love that response. So thank you, Dr. Kumanyika. This is a great pleasure to be here. I have to echo Dr. Christopher's sentiment as well. This is really a lot of fun. I remarked when we were standing waiting to start that everybody looks so young. So that's great. I'm glad you all are here. So I am the president and CEO of the Black Women's Health Imperative, and we are an organization dedicated to the health and wellness of the nation's 20 million Black women and girls. We've been around a little more than 30 years, and we are the only national organization with this focus. After 30 years, there's still only one. So when I took the job about a year ago, a little more than a year ago, that surprised me and in some respects sort of saddened me that there was only one, but it also made me realize, well, if there's only one, then we better do some serious work. And for the last 30 years or so, we actually have done some pretty serious work, and we've got our work cut out for us. So I'll just say, sort of by way of introduction, we're focused on chronic disease prevention, risk reduction. I'm sure you all know the chronic diseases we might be focused on. Sexual health and reproductive justice, and making sure that women have access to health insurance. But not only access, but understanding what it is, what to do with it, how to use it, and also the connection between health insurance and health stability and financial stability. So to that end, one of the initiatives that we're focused on is trying to look at what health means to Black women. When I first came on board, we did a quick poll to just ask Black women to define health. You know, just give us words and phrases, whatever this means to you. And I don't know, we collected several hundred words and phrases, and what we found was that about 80 to 85% of the words and phrases that Black women used to define health were psychosocial. I'm calm, I'm at peace, I don't have any worries. About 10% of the words were financial. I can pay my bills, I have enough money, I can take care of my family. Only about 5% of the words had anything to do with physical health. You know, I'm strong, I'm healthy, I'm disease-free. So what that suggested to me was maybe two things. After 30 years since the Heckler Report, of studying health disparities and researching and implementing programs and seeing that things are not better, in fact, in many instances worse 30 years hence, that maybe we've gone about this work differently or incorrectly, and that there's opportunities for change. But the other thought that occurred to me was that Black women were saying to me, you know, if I can get my head right and my spirit right and my money right, I can take care of everything else. So to that extent, that's what we're focused on, helping Black women get their heads right, their spirits right, and their money right, and we'll take care of the health issues. And I think over the next few minutes or hour or so, you'll hear some interesting ideas from all of us about how we're going to make that happen. So thank you.
Sorry.
Hi, everybody. Welcome to Happy National Public Health Week. So, you know, as I reflect on this conversation already today, and Dr. Christopher's comments in particular, you know, it brings me back to why we came together to create 100 Million Healthier Lives, whose purpose is to fundamentally transform the way in which everybody thinks and acts to improve health and well-being in the country. As a country, for better or for worse, we have a belief system that says that if we want to improve health, we need to improve healthcare. And believe me, as someone who is a part of the Institute for Healthcare Improvement and has spent the last 10 years working on improving the healthcare system in a safety net system like Cambridge Health Alliance, where 80% of people are in public insurance, where half of the people speak a language other than English as a primary language, I see the value that improving the healthcare system and improving effective access to things like primary care can give. But if you really sit and have the privilege of listening to people's stories, you know that it's exactly as Linda said, that what people need to be healthy goes far beyond that. And yet every time we think about how we're going to improve health, the vast majority of time, people tend to turn toward a solution within the walls of a healthcare system. Now, that's where a lot of resources are, so that's natural, but I think it goes beyond that. We've gotten used to the feel of that tool in our hand. You know, we know what it feels like, we understand how to use it, we feel a sense of confidence and competence in it. And so people keep using it over and over again, even though we know that at least in this country, when we look at the actual contribution to premature mortality, access to healthcare only represents 10% of the puzzle. And, you know, if you were building something, and you had a choice of having a hammer or a screwdriver or a wrench and saws and other things, or just one tool, you wouldn't choose to just use one. You'd actually think, what are all the things that I could use to create something different? And I would suggest that if we want to create a healthiest nation 2030, if we want to raise the grade, if we want to build not a health care system, but a health system, we need to bring the tools together that health care, public health, community health, education, social sector agencies, and above all, people, families, communities have in tools to improve the health and well-being of each other, of themselves, and of the nation as a whole. And that's what 100 Million Healthier Lives is all about. It's about bringing people and communities and organizations together across sectors who have all committed and are holding ourselves accountable to an audacious goal. As part of getting to America's healthiest nation by 2030, we'd like to start by improving the health and well-being of 100 million people by 2020. Because at the end of the day, as is inscribed in the halls of the Institute for Healthcare Improvement, soon is not a time, some is not a number. So if we want to do something about it, what are we willing to hold ourselves accountable to do? Through unprecedented collaboration, holding ourselves accountable to wide-scale, innovative improvement that crosses across media, that brings people together across sectors, and helps us see data in a totally different way. And by changing system barriers such as policy, payment, and integration of data and stories so that we can actually begin to see the whole picture, we hope we can actually at least learn a tremendous amount on our way to helping 100 million people live healthier lives by 2020.
So now we get to hear a little bit more from each panelist in answer to a general question, and then we'll take the questions from you. I could start with you, Dr. Farley, and give you a chance to talk more about what role you think media can play. You know, why is this going to be different from what we've done before?
You know, increasingly we live in a mediated world, right? So we email somebody in the next cubicle, we spend all of our time looking at our smartphones, and we share videos with people, and that trend is going to only continue. And the words and images that we see all day long have a strong influence on us, much more so than we recognize. They influence what we think about, they influence how we think about them, they influence what we do, and as a result of that, they influence the world around us. For example, if those words and images present smoking as something which is sophisticated and sexy, then we're all going to have a more positive view towards smoking, and people are going to be more likely to smoke. On the other hand, if those words and images present smoking as something which is disgusting and smelly and risky, then we're all going to be probably less likely to take up smoking and probably more willing to be supportive of policies that protect people from the marketing of cigarettes. So those words and images are very powerful, and in public health, as I said, we haven't used them much, but we have great potential to influence them. These days, anybody can put a video up on the web. We can participate in that national conversation with images as sophisticated as anyone else can, and we think that we should do that. We shouldn't complain about how the media is portraying whatever, gun violence, smoking, social determinants, if we're not participating in the conversation with all the tools of modern media. And so our interest is in changing that national conversation and using all the tools that we can to do that.
Thank you. So now we'll come back to Linda about you know, what it will take to really move population health from the perspective of making sure that we don't widen the disparities. I'm sure that this is something that has been a part of your thinking, because as we go forward trying to save the general population, is it a concern that the black women and other high-risk populations will be even farther behind? Yeah,
and that's a, you know, sort of for us been sort of a question for the ages. I'm sure everybody here has heard that technology is disparities producing, because some people have access to effective technology, I should say, not just all technology, but effective technology, because some people have access to it and some people don't. So if you don't have access to the latest in mammography or colorectal cancer screening or whatever it may be, then you don't get to take advantage of the life-saving properties that it has. So part of what we try to do is, of course, make sure that women know about what's available, but again, just knowing about it isn't good enough if you don't have access to it. So what we've embarked on, and actually we launched this back at APHA last year, something we're calling the Black Women's Health Index. So there's never been an index of Black women's health, and the basic premise that we've come at this from is the assumption that Black women are inherently strong and resilient and passionate about their health, and in fact not defined by disease and poverty and obesity and all the other negative stereotypes that you see. And so we've partnered with the authors of the Black Women's Health Study, which has 20 years of, I think it turns 20 this year, 20 years of data on 59,000 Black women to actually come up with a composite index of what it means to be healthy, what a healthy Black woman is. And if you think Dow Jones Index, cities and communities can actually index themselves against this index and measure the value of the investment in population health in their communities, maybe even, if we're lucky, to the zip code level. But I just want to echo something that Dr. Farley said. Part of what makes this interesting is, great, it's lovely to have an index, but we get to take the data from the study and crosswalk it with social media so we can actually understand what Black women are thinking about, what is meaningful to them about health and wellness, and marry that with analytics, actually create predictive profiles so that we can then implement programs and messages, particularly messaging that helps women understand what they can do, also gives us the ability to predict what might be most effective from a program perspective or messaging perspective to get women from one place to the next, to adopt one behavior over another, but also to work with policymakers to get them to understand what needs to happen. And those who know me know that I never shy away from shaming policymakers if it'll be effective. So it allows us to frame the issue of disparities reducing activities and inequalities in general, so that the correct answer is either yes or because we don't like motherhood and apple pie. And so far, I haven't come across anyone who's willing to say that to me, at least not to my face. So part of what we have to do in understanding this and making sure that we don't make the matter or make the issues worse is help policymakers and the everyday woman understand what the implications are and ramifications are of technology, of the latest research, of new developments, so that she can make the best choice for her and policymakers can make the best choice for the nation's health.
Thank you. Very provocative. So, Soma or Dr. Stout, I don't know if we're using first names or titles here, but so the healthcare system, in a way, has been talked about as something different from public health. We're competing for resources or attention or reputation. So you're going to bring those together. And if you could talk a little bit more about how that's going to work, it would be great to hear.
Well, that's a provocative question, I'd say. When I speak with anybody who's gone into healthcare, I have yet to meet a hospital CEO or even a CFO who gets up every morning to say, I am so excited this morning to be able to rob people in my community of the social determinants of health. I'm thrilled that women won't get access to housing or that disparities will increase because I am robbing the community of the resources it needs to be healthy. And I say that facetiously because I actually think some of the answer lies within that. When you actually go back to asking healthcare leaders their stories about why they went into this in the first place. And this is actually where we've started the conversation in 100 Million Healthier Lives, actually person by person, leader by leader, organization by organization, about what motivated you to do this work, what your story is. Universally, people went in because they wanted to improve the health and well-being of people and communities. And that actually provides a powerful common ground because they also realize that they're not achieving the outcome that they've spent often their entire lives doing, and yet are stewards of an infrastructure called, say, a hospital that may have maybe creating 2,000 jobs in the community, and feel responsible as employers to protect that, etc. And so when you invite people to go back to what they're in this for, when you align that with payment models that give them an option of walking in a different way and give them a support system to help people transition and start creating what we've been calling sort of low-hanging experiments around creating a continuum of health, you begin to get there. So I'll just give you a quick example, if that makes sense. I mean, some of it starts, I think, by just having a common piece that everybody agrees to. That could be smoking. It could be opiate abuse and substance abuse and its ramifications in the community. It could be violence. What we found is by bringing people together around something that everybody agrees to, and where people see that they actually hold different parts of the solution, and that if they can create a flood the zone strategy. And I'll just give an example from around smoking cessation that was used in our communities, where the public health department, we agreed on a common goal. The public health department worked to enact smoke-free policies in restaurants and parks. The housing departments worked to create, actually we mapped all of the public patients to public housing units, and the healthcare system invested in peer-to-peer coaching and behavioral interventions and access to smoking cessation products. Primary care made smoking a vital sign and integrated health coaching into every single visit. And the hospital facilities went smoke-free and engaged employers across the community to be able to do something. Then it suddenly became, instead of everybody sort of trying to lift a boulder up a hill, at one point, then another point, and another point, it was like we were all moving together. And suddenly people quickly realized how much more powerful those solutions are. And it also creates an opportunity to do something that I think is quite critical, which is actually to build relationships and help people understand the different kinds of the different pieces of the puzzle that other people hold. I think this is a powerful moment in the context of the Affordable Care Act, in that I think healthcare is more ready than it ever has been to actually begin to partner with public health. And I have to tell you, some people are afraid that having come late to the party of actually realizing that there are all these other factors, that people won't necessarily be accepted, or even that the desire to help will perhaps not be trusted. And we can understand why that would be. There's been history there. And yet, I think that the only way you begin to start developing collaboration is by building relationships, by trying it out, by acknowledging that there needs to be safe space for people to mess up and to, at the same time, have the relationships to work together and correct. It's, I think, one of the reasons that we're incredibly excited to be partnering with Healthiest Nation 2030 and 100 Million, so that we can begin to intentionally signal that in Healthcare 2.0 and Public Health 2.0, to adopt Dr. Christopher's words, this has to be a partnership where we're all working together for the health of the public.
Thanks. If any of the others have thought of things they wanted to say to add before we go to out for questions, feel free. If not, we can come back later if people are itching to hear what you have to say. Right? Okay, so it's your turn. Okay.